Hello and welcome to the channel. My name is Dr. Ernesto Lee. I'm the developer of the S.M.A.R.T minimally invasive bone grafting technique. And today we're going to have another video where we will be discussing now some of the reasons why S.M.A.R.T was developed. And this video is going to be a little bit different than the ones that we have recorded before, in the sense that it will be aimed both at dental professionals and also patients. So I will let you know right now that there's going to be some graphic images, some surgical photographs that will be presented during this video. So without further ado, let's just get into our presentation today. And we will be today discussing the reasons why S.M.A.R.T had to be developed. What were the cases that gave genesis to the need to find a new way that was different from the traditional bone grafting type of techniques. First of all, S.M.A.R.T stands for subperiosteal, minimally invasive, aesthetic-rich augmentation technique. It is a method that has been patented, and several patents have been granted that cover both the technique, instrumentation, as well as other devices. How is it that we got started with this technique is a question that is asked by many of the doctors that take our courses. And it has to do with the type of cases that I was exposed to during my years of practice, cases that I'm still trying to resolve. So many of them were the result of bone loss following periodontal disease, for example, bone loss following a negative outcome from bone grafting or implant procedures. These are extremely difficult cases to manage, and it is from the exposure and the experience in treating these kind of cases that we saw the need to develop something more predictable, something that was less invasive, particularly in the aesthetic zone. This is one of the type of cases that presented to me where, after performing the traditional surgical procedure for many years, you realize that if we chose to apply the same principles to this kind of patient, we'll end up creating some of the very same problems that we have been trying to correct through my years of clinical practice. So to just highlight some of the risk factors here is, and I'm going to once again include some descriptions for those viewers who are patients and not professionals. This patient is in his early 30s when he presented, and he has a high smile, meaning that when he smiles, he displays everything. All his front teeth are shown, the gum tissues are shown, and the red bubble that you see over the right front tooth, or what we call a central incisor, the right central incisor, is basically something called a fistula. And this is a result of an infectious process that is taking place because of something we call internal resorption, which in the middle screen corresponds to that dark cavity that you see in the middle of the tooth. So there's infected tissue there, and then it causes suppuration or pus to come out through that bubble you see there, which you call a fistula. This is a very difficult situation to treat because not only do we have the fistula and the resorption, but also there's no bone on that surface of the tooth. So to compound things and make them even more complicated, we have the presence of an implant adjacent to this tooth. And the risk of actually performing traditional procedures when an implant is present is that upon raising or elevating the gum tissues, we may end up having some area of the implant or the restorative components exposed. And that's always a very difficult situation to treat, if not impossible. So the question that we have to ask ourselves is whether or not traditional surgical approaches called GBR will yield predictable implant aesthetics. And we're emphasizing here predictable. I mean, not the fact that someone may be able to get away with a good result periodically, but we're talking about predictability. And for that, I think we need to define our goal. So what is it that we want to achieve when we talk about implant aesthetics? And that will be an appearance, once the implant is restored, of that implant restoration, that emerges from the soft tissue pretty much in the same way a natural tooth does, or in the same way a tooth-supported restoration, a crown, for example, does. And you see an example of this on the screen. And if you notice around the teeth, you have gum tissue, right? It's a pink soft tissue that surrounds your teeth, and you have these peaks of gum tissue that we call papilla. So it's been very well accepted at this point that to achieve aesthetic results around implants in the areas that are visible and aesthetically important to the patients, you basically need to work with a peri-implant or within a peri-implant context as favorable. What does that mean? It means that the gum tissues that are surrounding that implant or implant restoration need to frame that implant restoration or implant in the most natural way possible, meaning that the peaks of the pink tissue, what we call papilla, have to be present at the correct level, and the margin of the gingiva, as we dentists call it, or the gum tissue, needs to be at the correct level at all. In addition to this, the tissue needs to show some kind of convexity that is similar to that which will be caused by the root of the tooth when it's present. So all these factors basically create an environment, a soft tissue environment, that will be leading to the achievement of an aesthetic outcome with an implant restoration. What is GBR then? This is the traditional technique. What is GBR? GBR stands for guided bone regeneration. And it is a surgical procedure that was developed many years ago and uses a barrier membrane to promote the growth of new bone at sites in the jaws that are deficient in terms of dimensions for proper function, for aesthetics, or even to allow the placement of dental implants. We call these defects or bone defects, and this is a terminology that is used to denote those sites where bone is insufficient. The photograph on the screen, and again, these are surgical photographs, so some of you that are maybe sensitive to the appearance of blood and so forth may want to just look away at this point. But again, this is informational for both patients or potential patients and also other dentists and dental surgeons. So what you see here is a case where there was a previous implant failure, and now bone had to be grafted so that we could actually gain the dimensions so that another implant could be placed. And the first part of this process, this is the typical GBR technique, is elevating or lifting the gum tissues. So incisions are made, and then we detach the gum tissues, and we refer to this as elevating flaps. So soft tissue or gingival flaps or gum flaps are basically just reflected or elevated on either side of the bone, and it exposes the area where bone has to be placed. So a biomaterial subsequently is placed to kind of make up that volume that's deficient, and that biomaterial is then covered by a membrane, and in this case you can appreciate that there is a titanium reinforcement of that membrane, and the membrane is secure with a type of sutures. It could also be secure with metal tacks and screws and so forth. So after a few months, you'll observe that the membrane can be removed, and under the membrane there will be new bone that has grown. GBR uses different types of biomaterials, and these include cadaver bone. It includes xenograft, meaning bone that comes from species other than human, and the most common one being bovine bone, and to a lesser extent porcine bone at this stage. Also, autogenous bone can be used either in particles or blocks. So autogenous means that the bone is harvested from the patient, from various donor sites in the body, and there could be a different part of your jaw, for example, including even the hip, but of course this is done in surgical environments. In this case, you see that some bone blocks have been used, and these are fixated with screws. So these procedures also entail the use of fixation devices and space maintaining devices. So it's not limited only to screws. There are tacks. There are metal meshes that are used sometimes. The problem is that GBR is basically a procedure where complications are common. And in this study, for example, you see that they found that 75% approximately of the what they call the stage horizontal group experience complications in GBR cases. So stage meaning that the treatment is done in phases. So the first stage being the bone graft, right? The GBR. The second stage being the implant placement. So this is the way in which most of the cases are managed, and you see 75% of them, okay, are basically complications, have complications. So of those complications, about 40% are dehiscences and infections. Infections obviously means that the area gets infected. It's colonized with bacteria, there's swelling, there's inflammation, there's purulence, pus, what have you. Dehiscences when a membrane becomes exposed, and this is a very common problem, very common occurrence in GBR cases, an example of which you see on the photograph that's on the screen right now. So the problem with these dehiscences is that you may get bone growing under the membrane that is sufficient to place the implant. However, it causes a tremendous disfigurement of the soft tissues that are surrounding the site. And you see here, for example, that the papilla, the little peaks of pink tissue that are supposed to surround each side of the tooth, are pretty much non-existent here. At the same time, there's recession already. So in the aesthetic zone, in the area that's visible from the front, for example, or any area that is aesthetically important to the patient, this is catastrophic because it makes it near impossible to achieve that appearance of an implant-supported restoration that emerges from the soft tissue like a natural tooth does. Unfortunately, these are depictions of what we more often see in our cases following grafting procedures that are, again, complicated with the outcomes having to do with infections, dehiscences, that type of thing. And the severity of these defects is related to the complexity of the augmentation. And this is something that has been documented in the literature and continues to be documented in the literature. So, for example, just to quote a few papers, Costin in 2013 found that advanced reconstructive surgery, particularly GBR, increased the risk for complications and compromised aesthetics. Also, less favorable pink aesthetic outcomes were found in augmented sites. Pink aesthetic meaning the gum tissue, the pink tissues. And there's a recommendation to use flapless surgical approaches, so whenever possible, and to limit any incisions of the papilla. So I think we can conclude, based on our clinical experience and based on articles published by a number of different researchers, that traditional GBR surgery does not yield predictable implant aesthetics. Okay? It doesn't mean that someone may at some point or another not have an aesthetic result. Yes, we've all seen cases of that. But the issue is, how often does it happen? Is it going to happen to you as a patient or to you as a practitioner that your next patient, where you do GBR in the aesthetic zone, will be compromised and will lead to a substantial complication that will not be able to be corrected aesthetically? So we developed the S.M.A.R.T method to treat complex high-risk scenarios in the maxillary anterior region, where traditional GBR techniques would have disfigured the patient maxillary anterior region, meaning upper front teeth. Okay? So what does this method consist of? Well, a small incision is placed remotely meaning away from the area that's going to be treated. Then we utilize laparoscopic surgical principles and specially designed and patented instruments to develop a tunnel under the soft tissue, under the gum tissues, to access the surgical site. And to this tunnel, we're going to deliver a combination of biomaterial and a growth factor. No membranes are used. No bone blocks are ever used. No screws or metal meshes are used in this technique. Now what you'll see is a diagrams depicting a cross-section. So this is basically if you were to look at a site where a front tooth, an upper front tooth is missing, we actually just do a cross-section, turn it and place it on the screen, and you can see from left to right what was the starting point and then what was the ending point. So just to describe, the layer that you see as a thick pink line, it corresponds to the gingival tissue. That means the gum tissue, right? And immediately below is a layer of tissue as denser that we call the periosteum, and that's immediately laying on top of the bone, which is basically the innermost gray structure that you see in the screen. So after we make that small incision, we use our instruments to actually tunnel through the incision and actually elevate the soft tissues away from the bone, creating a pouch. And a biomaterial combined with a growth factor will be delivered into this pouch that will then cause an increase in volume. Volume that will be not only sufficient for implant placement, but also sufficient to resist bone loss in the future. And studies have also supported this. The thicker the bone, the more resistance you're going to have. The resistance you're going to have to bone loss as the implant just gets up there in years. So no incisions or suture lines are there to interfere with the healing of the bone graft. The growth factors that we use actually activate the stem cells, and this results in a natural wound healing process that's very similar to healing of bone fractures. Let's go back now to our patient and the one that I'm using as an example. And I like to use this case because it was one of the very first cases that were treated with the S.M.A.R.T technique as we developed it. And the problem here is that should we extract the tooth with the resorption, with internal resorption, right, which will be the right front tooth or right maxillary central incisor, what will happen is that there will be a tremendous amount of remodeling. The patient will probably lose both papilla. The patient will also have recession, and there's going to be a tremendous lack of volume once this tooth is taken out and the bone is remodeled, because you see that there's no bone covering the front portion of the root, or as we dentists call it, the labial surface of the root. So that's clearly not a good outcome, because the patient also has placed a restriction on us in terms of timeline. He's getting married in 8 months and he wants to look great, handsome for his wedding photographs. So what could we do within that time period? What could we do to avoid the pitfalls of creating soft tissue defects, gum defects, shadows, blunted papilla, etc., etc.? So in this case, the objective of treatment is to actually perform any type of procedures for bone grafting that will be necessary to achieve sufficient volume for the implant placement, but at the same time preventing recession, the loss of the papilla, or any type of soft tissue disfigurements. From left to right, you can actually see once again the appearance of the tooth to be treated, from the initial presentation in the center after the S.M.A.R.T graft was performed, and then all the way to the right after an immediate implant was placed. So I'd like to point out something in terms of the shape of the graft. You can see that it's irregular. Once again, it's one of our earlier cases, and we started using membranes. Why? Because we were training GBR, as has everybody else in the field of periodontics, oral surgery, etc., etc. So what happened is that we very quickly realized that once that membrane is placed in the tunnel, no matter how short that tunnel, once it hydrates and it mixes with the biomaterial, there's no way of controlling its shape. So what you see an indentation, right? And then a peak beyond that. So the indentation is where the membrane actually just folded over, and the peak is the excess of bone. So what we realized is that the excess of bone, right, proceeded to mineralize, bringing into question whether or not we actually needed the membrane. And there are actually a number of studies that also support the fact that in this system, using these growth factors, the membrane is not necessary. So what we did, to summarize it, is a S.M.A.R.T procedure. Well, first of all, we had to resolve the fistula. And for that, we had the help of one of their endodontic specialist colleagues, a root canal specialist. So he debrided the area, cleaned it out until the fistula basically was under control, because we could not do the bone graft with that fistula present. Number one. So then we proceeded to do the S.M.A.R.T bone graft, and several months later, we extracted the tooth and we placed an immediate implant. An immediate implant is in a site that's ideal, quote unquote, basically gives us the best chance at achieving the best aesthetic outcome. So in this case, we actually took the patient's existing crown and we retrofitted it to serve as an implant-supported temporary restoration. So that's the only way that we could actually meet the patient's 8-month deadline, so that he could actually, go get married, and subsequent to that, we could actually complete then the final restoration. So this is now the appearance of the patient following treatment. Now you may say to me, well, Dr. Lee, they look the same as a preoperative photograph. So what changed here? And actually that's a compliment, because what we aim to achieve is to have any changes, to have imperceptible changes following treatment, particularly again in the aesthetic zone with front teeth that are visible. If we look closely though at the photograph, for example, on the right side, you'll see that there's a punctuated white line, and that denotes the level of what we dentists call mucogingival junction. So it's the limit between that keratinized, stipple, more solid, harder type of gum tissue and the looser elastic soft tissue. And you see here there's a substantial discrepancy because the side with the S.M.A.R.T graft has basically a higher mucogingival junction with increased amounts of keratinized gum tissue. And this is something desirable because this is gum tissue that is more resistant to recession. This is an observation that we find consistently. So what you see on that photograph, right, the one to the right, is basically the patient's own crown, the pre-existing crown, that has been modified to be used as a temporary that is connected to an implant that was placed the same day the tooth was extracted. Okay, relatively simple. This is another case, and unfortunately, this is a freshman in college. So imagine your daughter. This is in college, and she has to basically suffer the consequences of her freshman year in college with this kind of appearance, which was visible when she smiled, very visible. Unfortunately, this is the result of 3 or 4 GBR procedures that fail. And this is a very, very difficult situation to treat, not just in terms of the technical aspects of it, which are challenging in its own right, but also the emotional and patient management aspects of the case. If we take a look at CT scans, you'll see that these teeth are lacking a substantial amount of bone, and as a result, their prognosis is not good, meaning that these teeth are going to eventually be lost. But the issue is, when are we going to extract them? Because as a good friend of mine mentioned years ago, hopeless teeth are not useless teeth. And in this case, we're using those hopeless teeth and we're erupting them through orthodontics using a technique known as forced eruption, because properly controlled, it will allow the soft tissues and the bone to actually proliferate in the direction of the eruption. So these teeth are going to be brought down, and the bone will actually, and gum tissue will come down with the brackets as the wire straightens out. And as it does that, the gingival architecture is preserved as well. But once we resolve that vertical aspect, so to speak, of the defect, now we have still a very thin crest of bone that needs to be augmented. And we also utilize a S.M.A.R.T technique in this case to increase the extent of the flap, because there are other issues where following orthodontics, there's thin bone and just very incipient or just a beginning recession that we wanted to prevent, and that's the reason why the graft was extended further. And this is a case as done with 2 small incisions. You see implants replaced after, but these implants replaced after the graft had healed. And this is now the appearance of the patient restored. Now, the gum tissues are not going to match the papilla. Those little peaks of tissue, of gum tissue between the teeth, will not match that of the other teeth. Why? Because that is something that is impossible, pretty much, when you have this degree of bone loss, of tissue loss. But that large vertical defect has been pretty much resolved. And for our colleagues that are watching, if you want to see more details about the case, You may actually just read this publication. I mean, we were encouraged to publish this as a case report by the editors of the Companion in Continuing Education in Dentistry. And this is the reference is up on the screen, and you may actually just look it up and browse through it. So 4 years later, this is the appearance. Implants are placed and resourced, and take a look at the amount of bone on the front surface of that implant. So that is actually going to ensure that recession, not ensure, but I mean make it a lot less likely for recession to occur. Okay, that has been shown as well. This gives a tremendous amount of bone, so that as the patient ages and bone remodels, there will still be bone covering that implant. And as you see here, this is before and after. All in all, a very satisfactory result for something that was a very, very difficult situation. So eventually what happened is that we gathered sufficient cases to just publish a prospective case series, mainly from our private practice. All the cases were treated by me. There are 21 patients involved in different treatment categories, some with implants placed, and at the time up to 30-month follow-up on some of the earlier cases, including one human specimen. Nowadays, we have approximately 12 human specimens at different times of healing, so we have a pretty good idea of what the wound healing in these situations in the system is like. But that is going to be the topic of another video. So I'd like to thank you for being with us today. And if you're interested in learning more about S.M.A.R.T, please visit our website, www.smartbonegraft.com. Contact us at the phone numbers that is being listed, or send us an email at smartbonegraft@gmail.com. Thank you very much for listening and for viewing this video, and we'll see you next time. Take care.